Thank you.
So why does sepsis matter, right? So always important to talk about the epidemiology when it comes to sepsis. So 1.7 million Americans a year, 30 million people worldwide are diagnosed with sepsis. That's increasing, probably because our definitions are changing, encompassing more of these patients. It's a factor, 270,000 deaths in the US each year. It's a factor in 1 in every 3 US hospital admissions. The healthcare costs are substantial, $20 billion each year, and that's probably an underestimate. And certainly, as I'll talk about later in this lecture, hospital readmission, something that we're paying more and more attention to, excess days, readmission, it's a huge factor in your hospital readmission. And certainly this is something that you guys encounter quite a bit on the medical wards. So this is why it should matter to you. So we know it's important for the healthcare system, but when we look at where sepsis is diagnosed, broken down by the ED, the ICU, and the medical floors, this is the Mount Sinai Health System data. Here we have in the ED, most of the cases, about a little over 50%. In the medical floors, about 35% are where cases are diagnosed, but you can see the mortality is much higher. And the reason is because we just don't recognize them early enough. It's easy in the ED, they come in, we're getting vital signs every hour, we're evaluating them quickly. On the medical floors, it's much more challenging. And so we've tried to implement other things to help you with this in terms of managing and identifying these patients. And this is where the SIRS alert comes into play. And this is something that I'll introduce later on. But as you can see here, we still see a substantial number of patients diagnosed on the floor, and the mortality is quite high. Same thing in the ICU, but obviously when they're in the ICU, they're much sicker. So different patient population. But obviously none of this data really hits home, right? And we're all aware that the regulations in sepsis are very substantial. 3 and 6 hour bundle criteria, document this, document that, have a lactate in 1 hour, 3 hours, make sure you start pressors, early, but not too early. There's all this compliance issues, and we don't understand where it came from. And it actually came from this case right here. And this is a young boy, 13-year-old, Rory Staunton, who suffered a scratch on his arm during a basketball game at school. And he went to his family pediatrician the next day because he was feeling fatigued, weak, tired. The pediatrician sent him to the emergency department here in a hospital in New York City. And in the ED, they gave him some fluids for dehydration and sent him home. And the next day he returned in fluid septic shock and ended up dying in the hospital. So this 13-year-old boy died from a scratch on the arm. And this is where we get Rory's regulations, which was passed in 2013, and it requires all hospitals to adopt best practices for the identification of the treatment for sepsis, right? This case was reviewed. It did not meet the basic standards of care. And so now we have these protocols which were implemented to help identify and manage septic patients. And certainly, perhaps if this was done before, maybe this young 13-year-old boy probably wouldn't have died from sepsis. This isn't something we see that often in children, passing away so young. So just to give you some context, why it's important. So now I'm going to take it to you guys. Okay, so you have a patient, 72, coronary artery disease, hyperlipidemia, diabetes, coming into the emergency department, shortness of breath and cough. Febrile, blood pressure 96/68, heart rate 115, saturating 92%, but tachypnic at 24. Lethargic, but protecting the airway, coarse breath sounds bilaterally, typical thing that we see, right? Labs, leukocytosis of 17, platelets of 72, creatinine 1.6. And of course, I got to throw that influenza COVID negative. And then you have this chest x-ray over here. So the diagnosis, this isn't going to be a question that you guys need to know. It's pretty simple, bacterial pneumonia. I think everybody would jump to that. But now I want you to answer for me, based on the information provided, how would you classify this patient? Is this SIRS without infection, sepsis, severe sepsis, or septic shock? So hopefully you guys have logged in and you can start texting your answers. As the numbers come in, everyone changes their answer. Okay. So if we were to look at it, depends on the guidelines. If we're going to use SEP2 guidelines, technically this patient needs severe sepsis, right? And we're going to explain why. So SIRS without infection, I think we'll all say that, that's not the case here. Certainly this patient has an infection. Now, if we're talking about the SEP2 guidelines, we have sepsis, severe sepsis, and septic shock. Severe sepsis is just SIRS, 2 criteria with a source or suspected source of infection. Severe sepsis is sepsis with organ dysfunction. And here we could say thrombocytopenia, AKI, altered mental status, are all organ dysfunction. So that patient would meet severe sepsis. Septic shock is actually somebody who's persistently hypotensive despite adequate fluid resuscitation and or a lactate greater than 4. So you're not wrong by saying sepsis, severe sepsis, or septic shock. It depends on which criteria are you using. If you knew a lactate and that lactate was 4.5, that patient would meet criteria for septic shock based on the SEP2, but not on the SEP3. So there's different definitions. Can everyone appreciate that? So there's not always one right answer. And this is where the complexity in sepsis identification and management really comes into play. So while we think of sepsis as something new, and we have these criteria, SEP1, SEP2, SEP3 criteria, we have to understand that sepsis is not new, but the complexity associated with it has been understood for a long period of time, all the way back into the 4th century BC with Hippocrates, where he first described sepsis, described it as the decomposition of organic matter, process by which we have wounds fester and flesh rots. But it's been, it's permeated all facets of society. And here we have Machiavelli in the 15th century Italy describing sepsis and creating an analogy to insurrection in politics, describing it as the physicians say of hectic fever. And this is a quote we probably can all relate to, that in the beginning of the malady, it is difficult to detect, but easy to treat. In the course of time, having been neither detected nor treated, it becomes easy to detect, but difficult to treat. Right? This is something we can all relate to. The patient who's coming in, we don't know if it's sepsis. You don't treat it, they go into septic shock, all of a sudden their mortality is quite high. And all the way into World War II, where it was used as a propaganda tool, right? Don't aid Hitler in getting sepsis, right? So sepsis has permeated all facets of society. This isn't something new, but we tend to identify it as something more recent because our criteria of diagnosis has changed so frequently over the last 15 to 20 years. And if we were to put it into context, this is how we would talk about sepsis and clinical criteria. So 1992, we have SEP1. We're all familiar with SIRS criteria. SIRS, to some extent, has been removed from many of the definitions in terms of SEP3, but it is still a very, very useful tool for our early identification. And it's still incorporated into the SEP2 guidelines, which is something you need to know because this is what CMS and the Department of Health uses for identification of sepsis. So you have to be aware of the SEP2 guidelines. So hyperthermia or hypothermia, tachycardia, tachypnea, or a leukocytosis or a bandemia. 2 or more of those with a source of infection is sepsis based on the SEP2 criteria. As we talked about, sepsis associated with organ dysfunction is severe sepsis. And if you have sepsis with arterial hypotension despite adequate, and adequate's in brackets because nobody really knows what adequate means, right? Adequate is not 30 cc's per kg. That's a number you need to know, but that's just a baseline resuscitation volume that you want to start with. So adequate has not been really defined as of yet, but despite adequate fluid resuscitation or a lactate greater than 4, that's septic shock. So you can see in our previous question, this patient could meet severe sepsis or septic shock criteria. You don't have all the data, so certainly you'd want to lactate on that patient. And most recently, the 2016 SEP3 guidelines, which have been endorsed, advocated for, and embraced by many of the academic societies. However, it has not been endorsed and embraced by the Department of Health, by CMS, which is the regulatory bodies which we have to report all our data to, which rely on you as the physicians who are identifying and treating these patients. It relies on you to identify them. So it requires the SEP2 guidelines. These SEP3 guidelines are more of an academic approach. So we redefine sepsis and septic shock. And one of the important things that we find here is that severe sepsis has been removed from the SEP3 guidelines. So sepsis is now life-threatening organ dysfunction, a dysregulated host response to infection. That's a very good description of sepsis. Septic shock is a subset with profound circulatory, cellular, and metabolic dysfunction that substantially increases the risk of mortality, right? That's how we define it now. And I think this gives you a better understanding of what sepsis truly is compared to the SEP2 guidelines. And then our clinical criteria. We use the SOFA score. Probably many of you have heard of the SOFA score, sequential organ failure assessment. I'll go through that in a second. But it has to have infection with 2 or more SOFA points. And you got to remember, these have to be above baseline. So if somebody has CKD or is on home oxygen, it has to be 2 points above their baseline to qualify for sepsis. And then our septic shock definition, again, is changed. So it's persistent hypotension requiring vasopressors. So they need to be on vasopressors to be in septic shock. And you have to have them to maintain a MAP greater than 65. And you have to have a lactate of 2 or more, right? So you need to fulfill all those criteria to have septic shock in the SEP3 guidelines. So I introduced this to make sure you guys understand that there's different definitions, and also to show you the complexity with what we're dealing with when we're trying to identify. So you can imagine if we're having trouble identifying sepsis, then it's going to be equally difficult for you guys to identify, diagnose, and manage within a 3 and 6 hour bundle criteria. And this is where all those complications come in. So what are the various scoring systems, the systems evaluated in the SOFA score? I don't expect you to memorize this. This is just to show you that when it comes to sepsis, almost every organ system, I would say, in fact, every organ system is involved to some extent, some more than others, depending on the site of infection and obviously your host. There's a lot of interaction that comes into play. But we have main organ systems over here, and you have your SOFA points over here. So respiration, we look at our PF ratio. So you need an ABG in order to calculate that. Coagulation, we look at our platelets. So you're going to need a CBC to look at that. Hepatic function, bilirubin. So you need a hepatic function panel. Interestingly, cardiovascular, we're looking at mean arterial pressure and the use of vasopressors to maintain that mean arterial pressure. Interestingly, there's no troponin that's included here. And I say that's interesting because more and more data is coming out on the utility of troponin in septic patients and how there is a strong prognostication in terms of morbidity and mortality independent of underlying coronary artery disease. So you might be seeing scoring systems change over the coming years as more of this data is coming out on troponin. BNP to some extent as well, but not as well correlated as troponin. Your GCS to determine your central nervous system. How many of you can calculate a GCS off the top of your head, right? Not many can. And then renal, you're looking at your creatinine, but you're also looking at your urine output. So that's equally important. Remember, creatinine lags 48, 72 hours behind your renal dysfunction. So you really want to look at urine output. So we have a comprehensive scoring system, but this isn't something that we readily have available to us. It's tough to get an ABG in all these labs to make that determination of the diagnosis of sepsis. So you can see it's even more challenging because we have this stricter criteria. So now let's go back to your patient. This is the same case. Nothing's changed. All the labs are the same. Now I ask you, you have this patient being admitted to you. What are your initial interventions? What would you perform first? I thought I would give it away by saying place the patient on a sepsis pathway in EPIC. Good, so 92% are correct. I like the fact that some people jumped on this because antibiotics first. We will talk about how important antibiotics are. But when you're dealing with patients in septic shock or sepsis, the criteria are to get blood cultures before antibiotics. That's something you always want to do. If you cannot get blood cultures before antibiotics, then certainly you don't want to wait 2, 3, 4 hours to do that, and you would give your antibiotics as soon as possible. But the way you want to manage these patients is use your sepsis pathway in Epic. And the reason why is it has all the labs, all the orders, everything you could possibly want, all the antibiotics in one location. You do not need ID approval for those first dose, so it gets you everything you need in a matter of minutes. So certainly you want to put them in the pathway and use the order set. Also, we can track these patients and you can see how they're progressing along their time and their stay in the hospital. Blood cultures, certainly before antibiotics. You certainly want to get a lactate, give your antibiotics, and then your IV fluids. Antibiotics first, you want to get your blood cultures first, so that's wrong. But certainly we want to get the antibiotics within an hour is our goal. Start peripheral vasopressors. Well, the blood pressure is 96/68. You really don't know the lactate yet, so I don't think that's the right answer. Consult critical care immediately. You know, the ED tends to do this. Once you do your AC rotation, you'll learn that pretty quickly. They consult you and you don't even have any labs, so they would jump all over D, but you're smarter than that, so you didn't go for that one. So I just want to take a brief moment to introduce you to the sepsis pathway. This is something you need to know. It's going to rely on you and your residents to be not only identifying these patients, but putting them on the sepsis pathway. This is something we've invested a lot of time, a lot of energy. I was involved in the creation of this pathway. I know it can be cumbersome, but once you understand how it works, you can see how it works for you. So under critical pathways, which is a tab at the top of your Epic, under your patient information, you'd go to sepsis order set, you'd place the patient on the sepsis pathway, and in the orders would be everything you need: your CBCs, your BMP, your blood cultures, your lactate, your chest x-ray, your CT scan, your urinalysis, everything you could want is there. Click, 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 done. It also has all the antibiotics you could possibly want. And it's organized based on undifferentiated sepsis, pneumonia, UTI, intra-abdominal. So everything has already been prearranged with the optimal antibiotics as well as the optimal dose for every patient. Now, these are loading doses, so you do not need to adjust them, okay? Even for renal failure. This is something that we don't do well. We always adjust for a loading dose, and that's not the appropriate standard of care. You're supposed to give a loading dose and then adjust based on renal function. So you never want to adjust these antibiotics. They've already been set up for you. You do not need ID approval for this, the first dose. This is to expedite the administration of antibiotics, so there's nothing holding you guys back from giving the antibiotics that you want, but you would need ID approval after that. All right, so this is set up for you guys. So once you put a patient on the pathway, you know what you want to treat. Everything's been chosen, the dose, the antibiotic, you just select and administer. And then I would also say, when it comes to fluids, that order's in there, and we've already put in Epic a calculator. So if the body weight is in there, the kilograms, it gives you the 30 cc's per kg. Okay, so that's already put in there, so you don't need to figure it out on your phones and calculate it. So it's already set up. You also want to document. So we have our sepsis alert note and then our sepsis reassessment. When you first see the patient, you do your sepsis alert note. When you're reevaluating, it makes sense, you would want to do a reassessment note. Again, these are already pre-filled, so it's just click, 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 click. It's not meant to add more work, but it's meant to try and simplify the process for you. It seems a little cumbersome when you first use it, but trust me, once you start integrating this into your practice and management of septic patients, it's very, very useful. And here we can see we've broken it up into pneumonia, urological infections, intra-abdominal, neutropenic fever, C. diff colitis. So everything is available for you guys. You don't need to sit there and look everything on UpToDate or Lexicon. Again, back to your patient. So you've seen him, you put him on the pathway, you're starting to get cultures, lactate, you used your order set, and now you're actually sitting there with the patient. And as the nurse is starting to get things going, you're looking to decide, well, what do I want to do with this patient? How do I know, are they going to get better? Are they going to get worse? Do they have a high mortality, a low mortality? What am I going to utilize? What scoring system is available to me to help determine that, something that I can utilize at the bedside? Okay, so 90% of you said Q-SOFA, 10% of you said PESI. No one said SOFA or BOVA, which is good. So SOFA, we utilize this. Remember, 2 or more points to diagnose sepsis. But like I said, who's getting an ABG? You don't have a CBC. You don't have a BMP, a hepatic function panel. You're not sitting there calculating a GCS. So it's really not useful at the bedside. This takes a little bit more time. So certainly not SOFA. PESI, that's our pulmonary severity index score, right? Our pulmonary embolism severity index score. So we're not using this for sepsis. BOVA, again, is another scoring system that we utilize for pulmonary embolism. So Q-SOFA, right? 91% of you got Q-SOFA. So definitely this is a quick SOFA score, something you want to be familiar with. This has been validated in a few studies already, and it's something that's endorsed by the Surviving Sepsis Guidelines. So we know Q-SOFA, but what are the components of Q-SOFA? And before all of you can start looking up on your phones, which I know everyone tries to do, put this up here. And this is more of a word cloud. So I want you to type in, what are the variables of Q-SOFA? So start giving me some words. This is not popping up. Blood. We'll see what that one means. Respiratory rate, good. Altered mental status, excellent. Tachypnea, good. So this is something that confuses a lot of people, right? It's tough to remember what the Q-SOFA is, but you guys got the majority of it. So here's your Q-SOFA. 3 simple things that you want to look at to help predict mortality and the need to escalate care and have these patients monitored in a higher level, a higher acuity setting. So remember, when it's with Q-SOFA, it's not a diagnostic tool. It's not a SOFA score. It's a screening for outcome, right? So you're not diagnosing sepsis with this, but you're identifying patients who have a diagnosis of sepsis who might have a worse outcome. So we use respiratory rate greater than 22, systolic blood pressure less than 100, so different from a lot of other scoring systems that we're familiar with, and then altered GCS, so altered mental status. If you have a score of 2 or more, your in-hospital mortality is greater than 10%. And it's recommended that these patients be evaluated for a higher level of care. In simple terms, an ICU screen, right? Makes sense. If somebody's hypotensive, if they're tachypnic, if they're altered, this is probably somebody you shouldn't be sending to 9B and then following up on them in the morning. So utilize your Q-SOFA. I think one of the things I've started to incorporate in my practice is when I'm screening a septic patient, if I'm screening them out or I'm screening them in, using some of these tools can help rationalize your thought process. Other people can understand why you're doing certain things that you're doing. And even if you need to change your mind, people see at that time, hey, the Q-SOFA was 0 out of 3. It made sense that the patient didn't need an ICU or needed an ICU screen, but things have changed, right? And you're documenting this and you're using these tools to your advantage. Good. So now you've identified certainly this patient, right, is lethargic, systolic less than 100, is tachypnic. So this patient should probably be evaluated for a higher level of care. Step down or an ICU. If we had a step down, probably be appropriate, but an ICU here. Good. So how do we classify septic shock? Now we're moving to a little more physiology. So if we were talking about septic shock, I think all of you, if I put up another question, would jump to distributive. And you wouldn't be incorrect. That's absolutely right. It is a distributive shock. But it's much more complex than that. Many of these patients who come in are hypovolemic. They haven't been taking PO. They're dehydrated. So certainly there's a hypovolemic component outside of the distributive shock that you see in these patients, outside of that vasodilation. Additionally, and becoming more recognized and more identified, is the cardiogenic component to septic shock. So initially when you have sepsis and they're hypotensive, you have peripheral vasodilation, your SVR, systemic vascular resistance, decreases. So your cardiac output tries to increase to compensate. So tachycardia and increased cardiac output. However, over time, you then have dilation of the ventricles and you have decreased cardiac output, and we have septic cardiomyopathy that develops. And like I said, it develops more frequently than we are identifying it. So certainly this is something that you want to take into consideration. Some of these patients also have a relative adrenal insufficiency. So that can certainly lead to hypotension and then hypoperfusion at the macro level. And then some of you might be familiar with the term of cytopathic hypoxia, or also known as cytotoxic hypoxia. And this is basically one of the fundamental problems with sepsis, and that's the inability to utilize oxygen at the cellular level. And that comes down to mitochondrial dysfunction. So all of these things come into play. So it's not just distributive, although that's where we're going to put these patients in our little clean algorithm for how we're defining shock. But these are all the things you need to take into consideration and to manage when you're dealing with a septic patient. So how do we conceptualize this and put this into some context? I've talked about SEP 1, SEP 2, SEP 3, how we classify shock, and right, it seems like it's all over the place. And this is one of the challenges when you're dealing with sepsis. It involves every organ system. It's not as neat and clean as a STEMI, where it's just involving the heart. Everything to some extent is involved. And so when I want you to be thinking about sepsis in terms of its pathophysiology, is defining it as a homeostatic imbalance. And the 5 main areas where we have homeostatic imbalance is listed here. And this is how I've defined it. This is how I teach it to the fellows when I present at conferences. This is how I try to define sepsis, and it makes sense, right? So there's an imbalance between vasodilation and vasoconstriction. This is something that everyone will agree with: hypoperfusion, so a low mean arterial pressure, but also hypoperfusion at the microcirculatory level, and this can affect any organ. Imbalance between pro-inflammatory and anti-inflammatory pathways. So we're familiar with that cytokine storm, and then later on in sepsis, that immunoparesis that can occur. But there's also anti-inflammatory pathways and resolution pathways. And more data and studies are looking at maybe there's a dysfunction in the anti-inflammatory pathway, and it's not just all pro-inflammatory pathways which are leading to the problems here. So there's an imbalance in that. Oxidant and antioxidant, again, oxidative stress, cellular damage, metabolic demand and supply issues. If you're having dysfunction at the mitochondrial level, you can't make ATP. If you can't make ATP, you don't have a functioning cell, right? And so you have decreased tissue energy substrates, thiamine being one of those as well, ATP, you have decrease in cellular function. And then you also have decreased endogenous release of vasopressin. This has been well described. This is why vasopressin is utilized as a vasopressor. Abnormalities in decreased production of corticosteroids, alterations of the renin angiotensin aldosterone system. This is where Giapreza, angiotensin 2, comes into play. This is a new vasopressor from 2018 based on the ATHOS 3 trial. So you can see there's multiple areas where we have dysfunction. And then when we get to the endothelium, coagulation and fibrinolysis. So we have microthrombosis that can develop in the microcapillaries of all the organs, again, leading to microcirculatory dysfunction. And something that we commonly see in septic patients, something that you guys are great at identifying, DIC. This is obviously at a larger scale when we have platelet consumption and this microangiopathic hemolytic anemia. But this is how I want you to start conceptualizing sepsis, this homeostatic imbalance. And your goal is to get your patient back into this normal homeostasis. So why does it occur? And this is where people have been asking questions, probably for thousands of years, but with real clinical studies for the last 40, 50 years. And the answer is we still don't know much about sepsis, but we do know a few things. We do know the innate immune system. We know the adaptive immune system. We know that, and this is a typical presentation of how a patient will become septic, right? It's not going to encompass everything, but just a general scheme. So we have lipopolysaccharides. So this is a bacteria being recognized by toll-like receptors, which are pattern recognition receptors on your innate immune cells, so your macrophages, your granulocytes, neutrophils being a big one, natural killer cells. And then it recognizes pattern recognition, pathogen-associated molecular patterns through their pattern recognition receptors. And that activates your innate immune response to then release inflammatory cytokines to stimulate your adaptive immune response, your T cells and your B cells, right? So that makes sense. That's a healthy response to an infection, whether it's a bacteria, viral, fungal, everything can lead to sepsis, but you talk about bacteria as being the prime driver here. So how do we then go from a normal cell response and a normal healthy response to an abnormal response? And this is a great diagram. It looks complicated. I'm just going to take you quickly through it, but this explains a lot of the things that we see, and it explains a lot of the homeostatic imbalance that I had talked about before. So here we have E. coli. We have something of your innate immune system. So we'll say this is, a monocyte. Looks like a monocyte, right? You have a toll-like receptor. Toll-like receptor 4 is the big one. This is the one that you need to know. This is on the critical care boards. They will ask you toll-like receptor 4. So I tell this to my fellows. That's the big one involved in the cascade. So pattern recognition receptors, recognizing pathogen-associated molecular patterns on bacteria or fungi or viruses, and then you stimulate the immune response. And this is normal. It acts in a paracrine fashion on cells next to you to stimulate and release of more inflammatory cytokines, right? And the goal is to kill the organism. But what happens is some of these inflammatory molecules start to act in an autocrine fashion as well, right? And so we're having this propagation of the immune system. And one of the things that's been identified over the last 10 years is these highly inflammatory molecules called inflammasomes. When they're getting activated in this autocrine fashion, the toll-like receptors and the cytosolic nod-like receptors get endocytosed, and they form these highly inflammatory molecules, which then release highly inflammatory cytokines. TNF-alpha, interleukin 1b, interleukin 18 have been identified. And it causes these cells in this area to act in abnormal ways. So neutrophils are releasing neutrophilic extracellular traps to try and trap bacteria, but they release them in an abundance, and then they start to cause microthrombi in the circulation. It also, in a healthy cell, it causes endothelial permeability. So we have increase in leukocytes, so even more cells are joining this, propagating the immune response. We have macrophages releasing inflammatory microparticles, which do a few things. One, they damage the endothelium, causing the exposure of tissue factor. And then we have fibrin deposition, activated platelets, and these neutrophilic extracellular traps causing more microthrombosis, more damage to the endothelium, more recruitment of the inflammatory response. And then these reactive oxygen species, which get produced by neutrophils and other cells of the innate immune response, do a few things. One, they cross into the cell and they act on mitochondria, damaging the mitochondria, right, inhibiting oxidative phosphorylation, and therefore your cell can't function. And if the cell can't function, these highly specialized cells can't do their job. So the endothelium breaks down, the hepatocytes can't function, the cardiac myocytes can't function. So you have cardiomyopathy, you have troponin leak. So they can't function in their highly specialized role. And then as we have more reactive oxygen and nitrogen species accumulating, they can disrupt the plasma membrane, and they can lead to something called pyroptosis. So we're familiar with apoptosis. This is something everybody learns in, freshman and high school, or you learn about apoptosis, programmed cell death. But you don't learn about pyroptosis, which is an inflammatory cell death. This is rupture of the plasma membrane, and you have release of the intracellular contents. And these intracellular contents are highly inflammatory, and they're recognized as foreign by the immune system. And we call these damage-associated molecular patterns. And this is the big thing being mitochondrial DNA. And so you're going to ask, well, why mitochondrial DNA? And I'll tell you that in a second, but you can see how this immune system, this initial response to the E. coli, coupled with destruction of your cells and release of damage-associated molecular patterns now causing an inflammatory response on this side, can lead to an overwhelming infection, how we progress from sepsis to severe sepsis, if you want to use the SEP2 guidelines, to septic shock, right? You can see how this overwhelming immune response occurs and how we can see we develop that homeostatic imbalance. So why are mitochondria so detrimental, and why are they recognized as foreign? Again, if you probably go back to your 8th grade biology textbook, you remember this thing called the endosymbiotic theory, right? Mitochondria are derived from bacterial ancestors. And many of the mitochondrial DNA are still recognized as foreign. They're protected within the cell, but they're recognized as foreign by the immune system. So these things like N-formulated proteins, DNA, transcription factors, when they are released through pyroptosis, they stimulate the immune system just like another infection would. So those damage-associated molecular patterns from pyroptosis propagate the immune system, coupled with the ongoing infection that's already occurring from the initial insult. So now you're starting to understand how we get from a healthy patient to somebody who's in septic shock. Now, when I teach this to a lot of the fellows, we go through each organ system, the heart, the endothelium, the liver, the kidneys, and we talk about in detail how it affects each one. I think that's beyond the scope here, but I think if you were to just reflect a little bit on everything we talked about, you can see how all those organ systems can be involved. And again, your highly specialized cells, the renal tubules, the cardiomyocytes, the hepatic cells, all of these are highly specialized, consuming a lot of ATP. If you don't have the substrates to resume their specialized roles, if they're rupturing, you can see how you can have organ dysfunction in each one of these. But things that we do in the ICU also perpetuate the critical illness and make things worse. So mechanical ventilation, obviously it's a life-saving thing that we do, but that can lead to VAP, that can lead to systemic inflammation if you're not having the lung protective strategies. 6 mils per kg, that's something we always talk about. Higher than that has definitely been shown to have mortality, worse mortality, and also propagate the inflammatory response. Sedatives that we're using for these septic patients when they're intubated, prolonged intubation, encephalopathy, delirium, ICU-acquired weakness, ulcers. The catheters that everyone's throwing in, whether it's central lines, A lines, dialysis catheters, Foley catheters, can lead to infection and also lead to VTE, which is venous thromboembolic disease. The broad spectrum antibiotics, everybody gets Vancomycin and Flagyl, right? You come in, you sneeze, you get Vancomycin and Flagyl. Your lactate's 2.2, you get Vancomycin and Flagyl. If you're lucky, you'll get Miro. So everybody's getting broad spectrum antibiotics. And when I'm in the ICU, I tell you guys this, when I was an intern in 2013, I remember rotating through the CCU, there was a patient who had ESBL. ID was down there, infection control was down there, the whole hospital was walking by, there's an ESBL, we can't believe it's ESBL. Now I walk in the unit, there's 4 or 5 ESBL, everyone's on contact precautions. That's partially our fault with the broad spectrum antibiotics that we're given. So this is just in the course of 9 years from me being an intern to now going through residency, fellowship, and as an attending, it's changed dramatically. And then finally, I threw in here fluids, and more fluids. You know, everyone is always debating about fluids. This can lead to a lot of problems, pulmonary edema, AKI, tissue edema in every organ that's encapsulated. The liver's encapsulated, the kidneys, the colon. It can lead to tissue edema and ischemia. So more fluids is not always the answer. And then I had mentioned this resolution pathways, more and more data looking at abnormalities in anti-inflammatory pathways, which may be the problem with sepsis, not so much all the cytokine storm. And what I want you to get out of this is the importance of the anti-inflammatory pathways. It is not passive. It is not just no longer having a pro-inflammatory cascade and then it melts away. This is a very active process. Interleukin 10 and TGF, transforming growth factor beta, are involved here. This is healthy control of damaged cells, apoptosis. This is using your innate immune response to go through efferocytosis and clearance of these apoptotic cells, elimination of the PAMPs and the DAMPs that we described earlier. And in the last 10 years, bioactive lipids have been identified, resolvins and protectants that reduce reactive oxygen species. T regulatory cells also play a role here. So just as much as the initial cells, the natural killer cells, and the neutrophils that we had talked about, all of these other anti-inflammatory cells are involved in resolution pathways. And so dysfunction here might be the underlying driver of why these patients progress into that pro-inflammatory cascade. All right, so we're managing your patient. We're going on to the next problem that you have to decide. So nothing's changed up to here, but now you know that the patient is hypotensive to 89/61 and you wish to administer IV fluids. What volume of IV fluids will you give to your patient? Excellent. So yes, like you said, start at 30 mils per kg, but you can give additional fluids. Remember, that's just a starting point, right? 30 cc's per kg, the data behind that is not strong. That's basically the amount of volume that the patients received before they were randomized to the 3 major early goal-directed treatment clinical trials, the Process, Promise, and Arise. So I'll mention those in a second, but on average, they got about 30 cc's per kg before they were enrolled. So everyone thought, hey, that should be a starting point. But there's no scientific, strong clinical evidence to say 30 cc's per kg is the correct number. But that's where we want to start. And then you can give more based on your clinical evaluation of the patient. So what are the Mount Sinai sepsis bundle recommendations? Here it is. It's based on the 3 and 6 hour bundle criteria. Don't memorize this. Everything that we had talked about, you would intuitively do. I see a patient, I place them on the pathway, I use the order set, blood cultures, early antibiotics, lactate. The only thing I would add in here is we recommend giving a 1 liter fluid bolus up front. This is based on the data that most patients will benefit and you will less likely cause harm by giving 1 liter. And if you do give 1 liter and they need the 30 cc's per kg or more, you've already started initiating fluid resuscitation, right? Document your note. If their lactate's greater than 4 or they have sustained hypotension, makes sense. You want to give 30 cc's per kg. You want to see how these patients are doing. So you're going to repeat your lactate. Lactate clearance associated with improved outcomes if you're actually clearing it by more than 10%. And then you want to document in your sepsis reassessment note. And then within 6 hours, it's recommended that you initiate vasopressors. You don't want these patients to be hypotensive forever. So you do want to initiate vasopressors earlier rather than later. There's been an update in 2018. Mitch Levy, Laura Evans just left NYU. Mitch Levy is at Brown. I've had the pleasure of meeting them both. They're phenomenal physicians. They are the leaders in sepsis management. They've recommended this 1 hour bundle. I've termed it a door to shock time. Within 1 hour, you do everything of the 3 and 6 hour bundle criteria, including starting vasopressors early, even if you haven't completed your 30 cc's per kg. Certainly, I don't think this is achievable. If we're talking about how do we even identify sepsis, how can we, evaluate these patients, to have you identify, evaluate, and do everything within 1 hour is not reasonable. But I think this highlights the importance of early initiation of these treatments, specifically antibiotics, and then obviously not having somebody maintain a blood pressure of 70/40 for prolonged periods of time. We know that can lead to end organ damage. So back to your patient. So you're saying, okay, I'm going to give 30 cc's per kg of fluid. What type of fluid am I going to give? And this is a ongoing debate that everybody loves to have. For some reason, this is the talk of the town. This is what stimulates every conversation with fluids. So what are you guys going to give your patient? So between normal saline and lactated ringers, so the debate goes on, balanced or unbalanced. I've had to listen to this throughout my fellowship. So I can tell you the data is leaning towards lactated ringers, but I don't think you are wrong by saying normal saline, and I'll tell you why. There is no right fluid for every single person. You have to look at each individual and decide what they need. So some might benefit from normal saline, some might benefit from lactated ringers. So I don't think you are wrong by choosing either one. If you were to just, based on the data, what it's saying, then you might go more towards balanced fluids, lactated ringers, plasma light, Hartmann solution. And that's based on these trials up here, the SMART trial, and they have their limitations. Everyone loves to quote the SMART trial. When you use balanced fluids compared to unbalanced, a reduction in combined endpoint of major adverse kidney events. Sorry, somebody's calling me. Just hang up on them. You guys are more important. So combined endpoint of major adverse kidney events in the balanced fluids, there's a reduction in that. But if you were to look at each individual endpoint, mortality, AKI, and renal replacement therapy, there was no difference in each one of these groups. But when you pool the data, there's a combined endpoint which shows a statistical significance. Okay, so you want to look at that data, each individual one. Now you guys are twice as important. And then if you were to look at a reanalysis, excuse me 1 second. Hello. Hi, I'm sorry, I'm in the middle of a meeting. I'll have to call you back. Bye-bye. They're persistent. So this is our SMART trial. A reanalysis of the SMART trial looking specifically at septic patients actually showed the same thing, a reduction in hospital mortality, lower incidence of major adverse kidney events, and a greater number of vasopressor-free days. And the idea is that normal saline leads to a hyperchloremic acidosis, which in some physiological studies have shown a decreased renal perfusion, and so an increased incidence of AKI, which leads to an increase in mortality. However, the SPLIT trial looks specifically at the increase in AKI when we're using, when we're using normal saline versus balanced fluids, and there was no difference in the incidence of AKI or the need for renal replacement therapy. So the debate's still up. I think, remember, normal saline or lactated ringers, you could give either one. There's no right thing for any patient. So this is where you want to use your clinical judgment. So now you have your patient again. Repeat blood pressure is 84/57 after 5 liters of fluid, lactates 4.1. So what's your next step in the management? You've given your fluids, you've given your antibiotics. What do you want to do next? Good. I agree with you guys. You want to start them on pressors. Fluids, and more fluids. Remember, we talked about that. A cumulative fluid balance is probably more important than LR or NS or whatever type of fluid you're giving. It's how much volume are they receiving? And more data is coming out on that. So you don't want to volume overload these patients. We always traditionally have given peripheral phenylephrine. For some reason, people always thought that was safer, but this is a pure alpha agonist. So it's more dangerous than even Levophed. So you can safely give peripheral Levophed. This has been studied. This has been shown. If you have good IV access, you just monitor the IV. You can safely give this. And we say you can give it up to 24 hours in an ICU setting. After that, it requires, attending documentation that we're continuing peripheral. But certainly you don't want this patient to be hypotensive for prolonged periods of time. So starting on vasopressors is reasonable to do. But giving more fluids, it depends on what type of fluid you're discussing. So some recommendations, and this is in the Surviving Sepsis Guidelines, the 2016 guidelines, say that if you've given a lot of crystalloids and you still feel that the patient is hypotensive, there is a recommendation that you can give colloids in the form of albumin, right? And that's based on the Albios trial. And it didn't show any mortality benefit when you're giving albumin in addition to crystalloids, but in a post hoc analysis in septic shock patients, there was a mortality benefit by giving albumin in that group. So that's why there's a second line recommendation. If you feel like the patient needs more volume and they've gotten substantial amount of crystalloids, you can consider giving colloids. How much fluids, how early do we want to start pressors? Again, there's no strong data, but the ongoing Clovers trial, which is set to be completed in 2022, is going to give us a lot of information. And this is probably going to be one of the most game-changing trials in sepsis management over the last few years. And it's looking at early vasopressors versus early fluid resuscitation and seeing if giving vasopressors early versus more fluids which one has beneficial impacts on the patient, mortality being the most important patient-centered outcome, but they have many predefined secondary outcomes. So 2022, in about a year or so, this is going to be coming out. This will change a lot of how we manage sepsis. I know we're coming into the last couple minutes. I'll try and get through the important things. I had mentioned early goal-directed therapy, Process, Promise, and Arise trial. This is based on Manny Rivers in 2001, showing if I throw a catheter in everybody and I titrate to make sure their hematocrit is greater than 30 and their SVO2 is greater than 70, and I have a Foley catheter in everybody, I can improve outcomes. That's no longer the case, right? What matters in these patients is early recognition, prompt delivery of fluids and antibiotics. And that's the cornerstone of all sepsis management. That's why these trials have not duplicated the same benefit of early goal-directed therapy. Antibiotics, we say early, and I say 1 hour because this is a landmark Kumar trial, which showed that each hour delay in antibiotics in somebody with septic shock was associated with a 7.5% decrease in survival. This has been replicated in other studies. So this shows you the importance of giving that early antibiotics. I'm just going to skip over this. Norepinephrine, first line vasopressor, we know that. If you're going to look at a second line, it's either vaso or epinephrine. Epinephrine, if you think that they have some cardiac septic cardiomyopathy. Vasopressin is also very beneficial because we have endogenous vasopressin deficiency. I like to get to this because everyone loves to talk about these things right here. So you have your patient on pressors. They're on levo, vaso, epi. You guys are now in the unit. What's your next step in the management of this patient in septic shock? So they're in refractory shock. What do you want to do next? You want to give more fluids, stress dose steroids, IVIG, vitamin C and thiamine, that wonder cocktail, or you just tell the family nothing, game over, he's done. Good, so I like your answer, stress dose steroids. Right, that is certainly the right answer here. This has been replicated in, these are the big RCTs. You want to know the adrenal trial, the corticus trial, the approaches trial. If you want to go further back, Anand, who's a very, very well-known intensivist out of France, has published a lot on the use of steroids in septic shock. The data is conflicting on mortality benefit. One thing that these trials all show is a decrease in vasopressor requirements and a faster resolution of shock. Now, if you were to tell me you have a patient with septic shock and I can give you something that's going to decrease all the other needs for medications and resolve the shock faster, you probably want to give that to a patient who's actively dying. So nobody should ever die without a trial of steroids if they're in septic shock. You'd be surprised how much it can change the hemodynamics of the patient. Vitamin C is junk. Remove that from your arsenal. It's based on this trial of from Paul Merrick out of Virginia. 47 patients. He showed 100% recovery when he gave vitamin C, thiamine, and steroids. There's some biological plausibility to this. Vitamin C, obviously important for the immune system, but has some anti-inflammatory properties. Thiamine is necessary as a cofactor for ATP in the citric acid cycle. So there's some biological plausibility here, but there's been big RCTs, the vitamins trial, the citrus Ali trial, which showed no mortality benefit, no change in SOFA score, nothing with using vitamin C, thiamine, and stress dose steroids versus steroids alone. In fact, there was a huge trial, the Victus trial, which was going to be the gold standard RCT for vitamin C, and that was actually stopped because all this other data came out showing that vitamin C has no benefit, has no role in these patients. You're going to always see editorials saying, well, maybe you got to give it earlier, maybe the dosing is incorrect. And that's a possibility, but the data doesn't support using this routinely in your patients. Neither is cytosorb. So the Japanese are more into this. They use hemofiltration to remove inflammatory cytokines. This would be the equivalent of us using tocilizumab, right? We use tocilizumab to bind the interleukin-6. This is a cytosorb filter to remove inflammatory cytokines. The problem is you don't know what you're removing. So you're removing inflammatory cytokines like interleukin-6, but you're also removing other things which may be beneficial for the patient. So this trial was stopped short as well because 60-day mortality was significantly higher in the treatment group. So we don't routinely do this, although the Japanese do this quite a bit. Your last question, I think. Yes, it is. So, your patient slowly improves after adding stress dose steroids. There's a resolution of his shock and his multi-organ failure. His daughter, who's been hanging around the ICU, tells you that he was very functional prior to this hospitalization and asks if he'll have future complications or any issues related to this hospitalization for septic shock. Based on the literature, as the intern, what is the most appropriate response? What would you say to this family? He will be stronger than ever since he received massive amounts of steroids. Most patients will return to their functional baseline within a short period of time. He has a high chance of functional disability and hospital readmission, or most patients only have minor issues and do not require continued medical follow-up. So what do you think? Look at that, 100%. All right, so the correct answer is most patients have functional disability. In fact, this is another area that's being actively investigated. Functional disability can persist for up to 3 years, but longer. Depression, anxiety, post-traumatic stress in patients and relatives. You can imagine having your family member go through something like this. Cognitive impairment, brain atrophy, readmission rates of up to 17.5% within 30 days. And actually, this is a huge thing that we're looking at. I'm part of the I'm one of the co-chairs of the Excess Days and Readmission Committee for Sepsis. This is something that we're looking at quite a bit. There's a large number of readmissions within 30 days, but specifically within that first week and that first week and a half, this is where you're going to have more than 50% of your readmissions with patients with sepsis. And this is out of CHEST, this table over here. This is looking at over 1 million patients. And what is their reason for readmission? Number one being infectious etiologies, they're listed here. Number two being GI, cardiovascular. Number three, respiratory and kidney, such as AKI. So the big thing to know here is, it's something that we're paying close attention to, is management of these comorbidities. So the heart failure, making sure that they're adequately diuresed after they've received their 15 liters of fluid in the ICU. Making sure that their COPD or their asthma is appropriately managed. Making sure that their renal function is returning to baseline. Making sure that we're de-escalating antibiotics so that they're not increased risk for multi-drug resistant and repeat infections. So those are important areas that you guys want to be paying attention to when you have your patients coming out of the ICU. Do I need to diurese? Heart failure management. What do I need to do for their inhalers? Because COPD is an independent risk factor for hospital readmission. Diabetes management, renal failure management. And I was just going to finally go over some initiatives and resources. We had talked about the sepsis bundle requirement. Again, you guys don't memorize this because you know how you want to manage a patient. I just urge you to utilize the template that we've created. It has everything there. You don't need to create additional notes. It's all set up for you. And if you do it correctly, you'll get a nice email from our sepsis coordinators, Karen McKenna and Rachel Schneider, and I'll be CC'd on that as well. The SIRS alert. Hopefully you guys are familiar with this. We call it the SIRS alert, not the sepsis alert, because it's meant to recognize any patient that is at high risk for decompensation. If this triggers, and this is the data we were looking at for the past year and a half, there is an over 10% in-hospital mortality for that patient, right? So if your patient gets a trigger on this, there's a greater than 10% chance they could die during that hospital admission. So this is why you want to pay attention to them. Here's the criteria here. It's a combination of vital signs, but also screening questions by the nurse. And then you would activate the whole sepsis template that we had talked about before. So I want you to be utilizing this. The inpatient icons, I'm sure you've been familiar with these before. You'll see these on the side of your patient when they trigger the SIRS alert. This helps to guide you through the management. E, evaluate. D, deliver care and document. R, reassess. And S means sepsis diagnosed, and you've done everything that you can for the patient, and hopefully they have improved outcomes. Final thoughts, just like we talked about throughout the presentation, appropriate fluid resuscitation, conservative fluid approach is now actually recommended. The Clover's trial, like I said, is looking at that, and that's a potential game changer. Vasopressors, norepinephrine, first line. I think most of you know that. Systemic steroids, you want to give it in refractory shock. Thiamine and vitamin C, garbage, don't use it. Therapeutic hypothermia, cytokine removal, stem cell-based therapies have all been evaluated. In fact, therapeutic hypothermia, a couple of years ago, that's the CAST trial, was stopped short because there was an increase in mortality when you give therapeutic hypothermia to septic patients. I mean, that's just common sense. Even the cardiologists know that. So you don't want to put somebody in therapeutic hypothermia if they're septic, but no data to support it. And you want to remember when you're dealing with sepsis, there's a lot of genetics coming into play. There's a lot of heterogeneity. So patient heterogeneity, risk factors, immunocompromised states, comorbidities, temporal heterogeneity plays into this when we're dealing with sepsis. We go with that cytokine storm to that immunoparesis to resolution pathways. All of these are involved and implicated in some way in sepsis. And then the biological variability is very, very important in terms of the rate of progression and the end organ dysfunction that we see. And then certainly the pathogen. If anything, COVID has taught us it doesn't take just a bacteria to really kill you. You know, you have somebody coming in with a virus such as SARS-CoV-2, and we see that inflammatory cascade. And I think you guys have been witness to that. You know, hopefully you've seen some of this maybe when you're in med school, but certainly our residents have seen tons of COVID, and we've seen these inflammatory cascades, and we can see how this has detrimental effects on all organ systems. So back to your patient, you guys did everything you could, early antibiotics, fluids, pressors, stress dose steroids. He's given you a thumbs up. You did everything you possibly could, and now he's going home with a little functional disability. Hopefully he won't be readmitted in the next week and a half, but we'll have to see. All right, guys, I went over a little bit. I tried to condense as much as I could into a 1-hour presentation for sepsis, touching on everything. If you have any questions, you can ask me now if we have some time. Always feel free to send me an email. There's my email right there. I'd be happy to talk to you about anything or send you articles that I've discussed here. I think it's always important that you review the literature on your own as well.
Thank you, Dr. Salonia, for teaching us about sepsis.
You're welcome.
Does anyone have any questions? You can always unmute yourselves, or you can write it in the chat if you don't like unmuting yourselves. I guess if there are any other questions later, we can always get them to you, Dr. Salonia.
Yeah, I'm sure you have another presenter coming up, so I don't want to take into their time.
We really appreciate your time. It was a fantastic lecture.
Thank you, Dr. Salonia.
Oh, thank you. All right, guys, excellent work. You got all the answers correct. And again, send me an email if you want some of the literature. I think this is high quality stuff. This is the RCT's game-changing management in sepsis.
Thank you again so much.
You're welcome.
All right, guys.